My name's
Yes.
Derrick Helphenstine. Today's January 20th, 2026. I'm sharing a little bit about, sorry about that. Ah, there we go. Substance use disorder and treatment. So a little bit about me. I have a bachelor's degree in elementary education, a master's degree in English as a second language, a master's degree in educational instructional coaching, a master's degree in substance abuse counseling. My current professional license is a temporary alcohol and drug counseling license, and I'm continuing on for my licensed clinical alcohol and drug counselor license. Currently live in Louisville, Kentucky, the USA. Was born in the USA in Louisville, and have lived many places throughout the world. This gave me a chance to kind of interact with different cultures around substance use and substance abuse, and see kind of how things are going. My family is from severe Eastern Kentucky. I say severe because the area is right on the border of Virginia and West Virginia. And many of my family members have had issues with substance use disorder. Some of my family members have actually passed away due to substance use disorder. And so that kind of, after 25 years of teaching, made me want to get into this career and look at how could I continue to help people, and primarily continue to help family members, and people who are close to me. Uh, in Kentucky, we do have an epidemic of HIV, hepatitis C, and an opioid epidemic. We are in the south of the US, and many of the countries in this, or sorry, the states in the south of the US are also in those epidemics. So I want to start by defining substance use disorder. Substance use disorder is a chronic, relapsing brain disease characterized by compulsive drug seeking despite harmful consequences. So, when we think about substance use, we can think about it in two different ways. We can think of it about it in recreational. Many people are able to recreationally use substances, drink on occasion, possibly, club drugs, marijuana, but don't have that chronic, compulsive drug seeking behaviors that go along with substance use disorder. And substance use disorder, it in the past has been called addiction, but addiction kind of became a taboo word. It became a word that kind of meant that someone had a moral failing. When we use the word addiction, there's generally certain pictures that come to mind of people who are possibly homeless, living on the street, only using drugs, not trying to better their life. And that's obviously not true for people who have substance use disorder. And it is important that we remember that it's not a moral failure. A lot of people, unfortunately, particularly people around religion, tend to say, pray your way out of it, or if you love me, you would just stop. But it's impossible because of the wiring pathways of the brain. And like I said, it transitions from recreational use to misuse, and then from misuse to dependence. Some of the substances that are commonly abused are depressants like alcohol and benzodiazepine. There are opioids such as heroin, fentanyl, and prescription painkillers, stimulants such as cocaine, methamphetamines, ADHD medications, hallucinogens such as LSD or acid and psilocybin or shrooms, and cannabis, marijuana, and its concentrates. Cannabis is actually one of those interesting ones that people often debate being whether it's a substance use disorder or not. In the past, currently it is um, categorized as substance use disorder if it is chronic and detrimental to health and sort of relationships and those other things. Historically speaking, cannabis has been something that's been used for painkillers and other things. And the strains that we had back in the 60s and 70s when it was very popular weren't the hybrid strains that we have now. And the hybrid strains that we have now have been bred and changed so much that they do actually cause dependence and change the neural pathways. Uh, and so marijuana and cannabis and cannabinoids are actually hugely up for debate because of that. But according to the Substance Abuse Mental Health Association, they are listed as a substance of abuse. If you think of addiction, we kind of talked a little bit earlier about how it rewires your neural pathways. The substances that we abuse sort of hijack the brain's reward system, and it provides a dopamine surge. So dopamine is that reward-seeking behavior that we kind of have uh, that tells our brain, "Hey, this is good" or "This is not good." Um, and when we have those substances that we partake in, initially our brain says, "Hey, this is great. It's alleviating a problem, probably a mental health issue. It makes me forget about, what's going on, whether I have bills due, whether my kids are sick, whether we have all of these other issues." And so your brain says, "Hey, this is great. I feel good. I feel a lot better." And so your brain constantly wants to seek that substance. And as you use that substance, it becomes so much that your brain says each time, "Hey, we're going to need more of this. We're going to need more of this. We're going to need more of this." And that's generally how it goes from recreational to a substance use disorder. The middle area being just misuse, but not abuse. And then kind of like in this picture here with the highways, you can see I like to use this picture because I like to think of it about, your brain has a certain way of doing things, particularly my brain. I generally drive the same way home every day. I do things in a specific way. And so when I'm driving home, currently I have this issue. When I'm driving home, one of the streets is blocked off and I have to go a different way. And, Google or Waze or Apple Maps or whatever, I tend to fight with them because I want to go the same way that I've always gone. And so I can think of that construction kind of like the the hijacking of my route home, such as like a substance use, it changes that pathway. And so I'm learning a new pathway to have to get home. And the likelihood is that when my former pathway has opened, and it possibly already has, I'm going to want to continue to do the new thing because that's what I've relearned. So, substance use disorder does cause long-term changes to judgment and decision making. Um, and it does it through that way. It can kill the gray matter in your brain. It can rewire neural pathways. It changes things to where what we once knew was not correct or not a correct way of kind of dealing with the world. We currently think this is okay. We do have several things that we can talk about in terms of who may develop a substance use disorder. There are some risk factors, such as genetics. If one of your parents was had a substance use disorder, primarily in terms of pills or alcohol, it is possible that that will trickle down to you. The genetic link is very small now that we've kind of gone through it and sort of investigated that, but it does happen. There are obviously environmental triggers such as trauma, PTSD, just post-traumatic stress syndrome disorder rather, peer pressure, and then a huge issue is those co-occurring mental health disorders. So we're talking about things like clinical depression, clinical anxiety, bipolar, type 1 and type 2. These things that we may not know that we have or haven't been diagnosed. We don't have medicines that are keeping our brain pathways in kind of a straight and narrow, normal path. And so we tend to sort of self-medicate. And that's really what substance use disorder is self-medicating, but with something that is harmful rather than helpful. In recovery, we talk a lot about peer pressure, and I think it's interesting because we always talk about social pressures and what's acceptable socially, and that's really living all over the world and being able to see what substances people interact with differently has been very interesting for me. For instance, I lived in Bolivia for almost nearly 2 years. And when I lived in Bolivia, there's a high use of coca leaf as a stimulant for being able to stay awake or work productivity. And it's kind of a socially acceptable thing. But if you take that into another area, such as the US, and someone's using that as a stimulant to help those things, then it becomes an illicit thing and falls under substance use disorder. So it's really kind of um, socially defined, but some of the things that we obviously know are substance use disorders are overarching worldwide. So when we think about people who are developing a substance use disorder, some of the warning signs that we might find are changes in their sleep or appetite. They may have bloodshot eyes. They may start becoming secretive about their habits, whether it's drug use or any other types of habits. They may have a loss of interest in their hobbies, and they may have sudden financial issues. This is kind of where the co-occurring disorders come in because you can see that many of these things are also linked with clinical depression, major depressive disorder, ADHD, anxiety disorders, and other disorders that may not coincide with substance use disorder, but may look familiar. Also, there are some psychological and social impacts. Obviously, substance use disorder can cause anxiety and depression. It can further exacerbate anxiety and depression if you currently already have it. It tends to cause isolation. Most people don't really want to do their drug of choice near particular people, whether that's their family, whether that's job, whether that's, church, and so they tend to isolate to do their drug of choice, and it tends to become one of those areas of isolation. Um, we see strained family relationships because of the substance use and because of the financial issues, because of all of those things that we mentioned before. And then for some people, they are considered functioning substance use disorder people, and they can continue with their jobs and other things. But for a lot of people, it leads to job loss, which of course then leads to anxiety and depression, then leads to isolation, strained family relationships. So it's really a cyclical thing. Obviously, the impact on physical health that we see is organ damage, such as liver, heart, and lungs. There's an increased risk of infectious diseases such as HIV and hepatitis, and obviously overdose risks. Like I spoke about earlier, in Kentucky and in the south of the US, most of the states, we consider them as red states. They're Republican states, and unfortunately, in those red states, funding is very cut for community health. And so we see a lot of those infectious diseases spreading, like I said earlier, such as HIV and hepatitis C. Um, and then again, overdose risks are very high because your brain continuously wires itself to say, I need more, I need more, I need more. and you're wearing out your organs, causing that damage, and then your organs can't function. And your brain says, well, I can't function without more. And so you take a dose that becomes lethal, and have an overdose. This is a model called the stages of change. And in the stages of change, you can see that there are, it goes from pre-contemplation to maintenance and relapse. Pre-contemplation is where someone has no intention of changing their behavior. They don't see that they have a problem. They're, not having any, they may be having those difficulties with the various factors, etc. Um, but they don't see that they have a problem and they don't need help. If you kind of bring up, hey, maybe you have a problem, that's when we have those fights about, hey, why are you telling me what to do? And strained family relationship issues. And then we move from pre-contemplation into contemplation. And in contemplation, the person's aware that they have a problem. Maybe they're aware that they drink too many beers throughout the week. Maybe they're aware that they're hungover at work, and it's kind of a problem. But they really don't know what to do about it, and they really don't want to do anything about it yet. That's kind of the wake up stage of, yep, something's going on, but I don't need to fix it. Then we go from contemplation to preparation. And preparation is the stage where people begin to think about wanting to fix their problem. And in preparation, that's when people start to seek, sorry, in preparation, that's when people start to seek out resources such as websites. They may seek out treatment facilities. They may seek out self-help groups. Um, they really become kind of self-aware on wanting to fix the problem. Um, then it moves into action. And in action, they're actively modifying their behavior, and they're making sure that any of the coping skills that they've gained, they're putting into use. Um, any of the knowledge that they're getting from whatever treatment they're putting into use, and they're using it to actually change their behavior and usage habits. And then we go into maintenance. And maintenance is considered sustained change. New behavior replaces old behaviors. Um, and they have less of a difficulty with having to actively use coping skills and mechanisms and actively change their behavior because their neural pathways have changed a bit backward to normal, what we call normal neural pathways, and their behavior is no longer centered around that dopamine that they would get from the substance use. They still do have cravings from time to time, but the cravings they realize are kind of a wave and they can ride out those cravings. So it's not really an issue in terms of um, sustaining change. But there are some times where action and maintenance do follow back into relapse, and people fall back into their old patterns of behavior and use. And they just that they start using again. They may not know why. They may go back into they go back into pre-contemplation generally. They're back at that part of it's not a problem now, or I had a problem, I tried to beat it, I can't, and they get stuck in that pre-contemplation of and contemplation of, well, this is just me. Interesting. I've learned since working in this field that relapse happens on average. It takes 7 times of someone trying to stop substance abuse or substance use disorder for them to change their pathways and their ability to sustain the maintenance. So 7 times, and it's very interesting because A lot of times we do think of it as, well, why can't you just stop? And so people do try to stop. And like I said, they fall back into relapse and stay in this area. And so it's just a very difficult thing to change your neural pathways. The DSM-5 is the Diagnostic and Statistical Manual. It is kind of the big book of disorders for mental health disorders. It also includes substance use disorder in there, and there are 11 symptoms of substance use disorder. The first area is impaired control, larger amounts over longer periods, obviously the inability to cut down, not the lack of desire, but not being able to despite wanting to. Time spent using their substance or recovering from their substance, and the cravings that they have when they can't think of anything else or the urge to use is too great. Continuing with social impairment, there's a role failure where they kind of have that job loss or they're unable to do work or school. Maybe they're not able to take care of their children at home or their home starts to fall apart. They have those social problems, which kind of become those conflicts between family or friends, which are caused by the drug, and then withdrawing from their social or occupational activities, or even recreational activities. And then we go on to into risky use. And this is where they have situations where it's dangerous. Maybe they're driving while they're intoxicated. Maybe they're driving while, they're drunk. They may be sharing needles. They may be doing those things that, are not only hazardous to themselves, but hazardous to other people in their vicinity. And then we go on to physical and psychological problems, which is knowing that the substance is causing their health issue, maybe cirrhosis of their liver, or they know that they have, lung cancer that they developed from something, but they just can't give it up or they won't give it up. Um, and then there's pharmacological criteria, which is tolerance, needing more of that substance to get to the same high, and the withdrawal of experiencing that physical and mental distress when they stop using, and wanting to continue to use their substance to avoid this. And when we think about determining the severity, it's an interesting note that tolerance and withdrawal from prescribed medical treatment, such as taking pain medication from a doctor prescribed by a doctor, doesn't count towards a diagnosis of substance use disorder. Many people who have substance use disorder, they do tend to, when they get on that medication from the doctor, abuse it and have those withdrawals. But it's a fine line and a tricky line to kind of say, is the withdrawal from not being able to use the drug, or is the withdrawal from having to have the drug and be dependent upon it, but not having it? And the diagnosis isn't all or nothing. It's based on the number of criteria that's met within 12-month period. For a mild substance use disorder, you only have two or three of those 11. For a moderate, you have four or five of those that you meet, and for severe, you have six or more that you meet. In terms of treatment, the levels of care, there is detox where a person may go in just to withdraw from a symptom, or from a substance rather, in hopefully a contained area that has the ability to help them, medically. So if there are issues with withdrawal, then there's residential and inpatient, and I currently work in a residential setting, which is inpatient. And then there's an intensive outpatient, followed by outpatient, and there's aftercare. So intensive outpatient would be after you finished a residential treatment or a detox, you would go into a program that is the same sort of recovery classes that you do in a residential program. And you do those generally for 3 days a week. Some places are up to five. Generally 3 to 5 hours a day, hence the intensive part, to help you kind of transition from um, using, or if you're in residential, transition out of residential into quote unquote normal life, and be around people who can help you with transitioning into all of those things while you're having the stressors that you will undoubtedly have when transitioning. ASAM is the American Society of Addiction Medication, and they have a continuum of care which goes from zero point 0.5, which is just the assessment and education for at-risk individuals, and it's not diagnosed. Um, and continues to increase to outpatient services, like I said, 9 hours a week generally, to intensive outpatient services, which are 9 to 19 hours a week. This is generally the average, but each state can actually have control over what they consider the correct number of intensive outpatient hours per week. And then a partial hospitalization program would be kind of a living arrangement where the person likely lives in a facility, but they only participate 20 hours a week within that facility in groups or clinical sessions with therapy. Um, but they may need a stable home, or they may have a stable home and need just the partial hospitalization program where they're not ready to transition to intensive outpatient and they need more hours per week. Currently, like I said, I work in residential and inpatient, which is 24-hour living support. Our program is 28 to 32 days. And, we are generally at a 3.7, which is medically monitored. We have medical staff, doctors and nurses on hand all day, because we do have issues with people abusing medication, even in our facility when it's strictly controlled. And so we have to have those supports in place so that people can transition to a lower level of care. Um, and then 4.0 is obviously the highest, and it's a medically managed inpatient care. That's 24-hour nursing and daily physician care. But the difference between like a 3.1 and a 3.7 and a 4.0 would be that in a 4.0, their movements are very, very, very controlled. We can think of it more as like needing more therapy and psycho interventions. And so if we think of people who maybe um, what we call a psych ward, those might be more medically managed inpatient and might fall under the 4.0. So my job specifically is to establish a therapeutic alliance with the patient, provide a non-judgmental space, and set collaborative goals. I apologize. And so that means that I'm not there to tell the patient what they need to do. Of course, being a teacher for so many years, I'm very good at being able to tell people what to do. But that doesn't really help anyone in terms of changing their behavior. And so we're there to kind of come to the same agreement and alliance in a space that they don't feel judged and that they're able to share and learn and grow. And then a big part of that is setting collaborative goals. I can set goals for people, but unfortunately, anyone with children or who's worked with other people, you know that if you set a goal for someone, then they may not meet it. And that's because there's generally no buy-in, because there's nothing that they're going to get out of it. The types of therapy that we use are cognitive behavioral therapy, or CBT. In CBT, a lot of time is spent identifying triggers and changing thought patterns that lead to use. And those triggers are the things, the people, places, and things that cause cravings that make the people want to fall back into using their drug of choice. We also use motivational interviewing a lot, and that means kind of being a sounding board for the patient, and having them find their own motivation to change. And we focus on meeting them where they are. Again, not telling anyone anything specifically how to do things. but kind of investigating their reasons for wanting to change, and then going into, okay, how can we do this, and creating those plans for getting that change underway. After those things, outside of my scope of residential support, there's group therapy and peer support. It offers the benefits, like I said earlier, of shared experience. You're transitioning into the world, you're having those same stressors and those same cravings and those same triggers. And a lot of those are through 12-step programs such as AA, which is Alcoholics Anonymous, and NA, which is Narcotics Anonymous, and Smart Recovery, which is an evidence-based recovery program that many facilities use. We do sometimes work with family therapy. We do have people who have codependency issues or family issues of loss of relationships and wanting to rebuild relationships. So we do often have therapy around that and bring family members in and discuss how the behaviors that the person with substance use disorder are exhibiting are detrimental and causing the loss of relationship, and trying to find ways to build bridges between the family or the close friends, partners. Um, and then medication assisted treatment, MAT, which is combining counseling with approved medications such as methadone, buprenorphine, or naltrexone. Those are the overdose drugs that we kind of talk about the most, or the ones that kind of keep the cravings at bay, for people with alcohol use disorder, or opioid use disorder primarily. Like I talked about just a minute ago, there are a lot of continuing programs such as Alcoholics Anonymous. Alcoholics Anonymous is a spirituality-based, not religion, but spirituality-based 12-step program. And it's designed to help people come to terms with their substance use disorder. It's designed to give them guidelines on how to achieve sobriety and continue recovery. It did start in 1935, and it does follow a very formulaic. You go from step 1 to step 12. You may go through different steps at times at the same time, or you may have one step that comes before another. But generally, it was designed to go in order from 1 to 12. There are lots of other 12-step programs for substance use disorder. There's Narcotics Anonymous, there's Cocaine Anonymous, there's Crystal Meth Anonymous, Heroin Anonymous, and Nicotine Anonymous. And these are all based around that idea that was created in 1935 of those 12 steps. And it just provides people who have a specific substance use disorder, for like narcotics or cocaine, to be in a group where they have support of people who are going through the same issues of using the same substance. So not just grouping everyone into the same group and saying, hey, we all have a problem, but the issues that come from our problem are likely very different. And it's interesting because a lot of people who fall under these different programs, they don't generally like to share in an open environment where people aren't going through the same thing that they're going through, because our brain kind of says, well, you don't know what I'm talking about, or you don't know how it is because you're not going through the same thing as me. Um, there are family programs like Al-Anon, which is for families of alcoholics, and there's a group called Adult Children of Alcoholics, and these are primarily based around helping to rebuild relationships and helping to educate families on kind of how the addiction process works, and kind of rebuilding or repairing some of those bridges that have been burnt or lost. And Al-Anon and ACA also, they do have a large part of um, people who attend them who think that they may be the cause for someone's substance use disorder. So maybe their parents' alcoholism or any other substance use disorder. And so they go to that as a type of therapy and learn that, it's not you that's causing this. But that also is a very difficult thing to kind of come to terms with, particularly if you've been in that situation for a long time. And maybe your parent is actually perpetuating the idea that you are the problem. And so some of the future outlook and prevention measures that we see and are some community programs like needle exchange sites, and those would be for intravenous drug use. They're places where people can go to exchange their syringes and their needles for clean new syringes and needles so that HIV, hepatitis C, and other things aren't being spread. They're designed to be sort of um, no fault and no judgment zone. It's just designed specifically as helping to kind of stop or lessen the spread of things, those HIV and Hep C that people spread when they share dirty or infected needles. And some of them may not even know that those needles contain those things. In some places, there are safe use zones where people can go specifically to use, which sounds kind of sort of backwards, but it's an area where people who are trained in possible withdrawal issues will be around so that if someone does overdose, if someone is having difficult withdrawal, then they're in an area where they're less likely to possibly pass away from drug use or withdrawal. And there's naltrexone education. Naltrexone is the drug, it's the opioid blocker that we generally use when someone's having an overdose. And it helps to stabilize the brain and stabilize some of the organ systems to give a better chance at someone coming through substance overdose back to life. And naltrexone is not a fail-safe. It is one of those drugs that when you use it, you can build up a tolerance to it. And some people build up so much of a tolerance that it's not even possible to help. And in my facility, there was a person who ended up having to be kind of having to be administered naltrexone 6 times because they built up the tolerance to it. Then there's also early intervention in schools, which is DARE. It's a community-based program which teaches students in schools about kind of the dangers of alcohol and drugs. And then it's also super important that the outlook of substance use disorders and changes so that everyone understands or more easily understands that it's not a moral failing. It's not because someone doesn't want to stop using. It's more of a dependence because of generally, like I said, a co-occurring disorder or mental health disorder. All right, and so that's all I have for my presentation, and I'm going to stop sharing and go ahead and look to take some questions if people have questions.